Welcome back to Dental Notes and Mnemonics. In previous video we discussed about the anterior crossbite, and in this video we'll be discussing posterior crossbite, its causes, types, and the treatment or the management part of posterior crossbite. So without any delay, let's get started with the video. If we see in the normal occlusion, the upper teeth should slightly overlap the lower teeth in both the front and at the back. When this relationship is reversed, it is called crossbite. So Prophet describes it as an abnormal buccolingual or labiolingual relationship of the teeth. We can broadly categorize them into anterior crossbite and posterior crossbite. Posterior crossbite is the one which affects the back teeth. That means it affects molars and the premolars. Crossbite can result from dental, skeletal, functional or environmental factors, and these factors may be in combination as well. Dental causes include abnormal eruption path of posterior teeth, retention of primary teeth with delayed exfoliation, malposition of permanent molars in the premolars, and early loss of primary teeth leading to space loss or drifting. Skeletal factors involve transverse maxillary deficiency. Occasionally there may be a widened mandibular arch or an arch width discrepancy between maxilla and mandible, which may be genetic or may be linked to craniofacial growth pattern. Functional factors arises from the mandibular shift due to occlusal interferences. These often appear unilateral but may result from bilateral maxillary constriction as a child shifts the mandible to achieve a comfortable bite. Apart from dental, skeletal and functional factors, environmental and the habitual factors may also contribute to posterior crossbite, such as prolonged thumb sucking, pacifier use, mouth breathing, nasal obstruction, and abnormal tongue posture can alter normal arch development. Crossbite can be classified in several ways. Based on etiology, it is of three types: dental, where the teeth are misplaced but the jaws is normal; skeletal, where the jaw structure is narrow or wide; and functional, where the jaw shifts during closing due to occlusal interferences. Based on the side, it may be unilateral, which is only affecting the one side, or the bilateral, that means both sides are in crossbite. According to the position of teeth, a buccal crossbite occurs when the upper teeth bite inside the lower ones, and the lingual crossbite or scissor bite happens when the upper teeth are completely outside the lower ones. If we look at how many teeth are involved in crossbite, it may be categorized involving a single tooth, a segment which involves a group of teeth, or it can be generalized across the whole arch. Finally, based on the dental age, posterior crossbite may appear in primary dentition, mixed dentition, or in permanent dentition. In the diagnostic evaluation of posterior crossbite, it is utmost important to take a good history, with particular attention to deleterious oral habits such as thumb or finger sucking. The clinician should assess the habit in terms of frequency, intensity, duration, and persistence. Prolonged or forceful sucking can lead to transverse maxillary constriction and lingual tipping of mandibular posterior teeth. The correction of oral habits is must if we want to prevent the relapse after the correction of posterior crossbite. Examination of a suspected posterior crossbite should begin with extra oral assessment, noting any facial asymmetry or deviation of chin on closure. Intraorally, the clinician should evaluate the buccolingual relationship of the posterior teeth in centric occlusion, paying attention to whether the maxillary posterior cusp occlude inside the mandibular posterior cusp. It is essential to differentiate between a true skeletal crossbite and a functional shift by guiding the patient into centric relation and comparing the intercuspal positions. Assessment should also include the width of the maxillary arch, the inclination of posterior teeth, and any associated crowding or dental compensations. palatal morphology, occlusal wear facets, and midline discrepancies should be documented, as these findings assist in confirming the diagnosis. According to Graber et al., dental cast analysis play a crucial role in diagnosing posterior crossbite by assessing transverse discrepancies between maxilla and mandible. Key parameters to evaluate including the intercanine width. In normal maxilla, it is around 28 to 30 millimeter, while the mandible it is about 22 to 26 millimeter. Whereas the maxillary value less than the mandibular value suggests transverse maxillary deficiency. Intermolar width in normal maxilla is 48 to 51 mm, and in mandible it is 44 to 47 millimeter. Whereas smaller maxillary measurement than the mandibular indicates a likely skeletal crossbite. Arch symmetry should normally be U-shaped and balanced, with asymmetry pointing to possible unilateral skeletal or dental problem. The curve of Wilson should show slight buccal inclination of upper molars. Loss of this curve or excessive tipping suggests a dental component. Tooth position should be centered within the alveolus, and buccal or the lingual tipping indicates dental crossbite. Cast midline should be coincide. Deviation without a mandibular shift suggests a skeletal asymmetry. Importantly, a cast can be examined in centric relation rather than centric occlusion to distinguish true skeletal asymmetry from a functional mandibular deviation. Radiographs are essential in differentiating skeletal, functional, and dental posterior crossbite, particularly when the clinical findings are inconclusive. The PA cephalogram or posterior interior cephalogram is the primary radiographic tool for evaluating transverse skeletal discrepancies. In a true skeletal crossbite, the maxillary width measured between the right and the left jugal points is less than the mandibular width between the gonian points. Normal right and the left jugal point width in adolescent ranges from approximately 58 to 62 mm, and a difference of more than 4 mm between the maxillary and the mandibular width indicates skeletal maxillary constriction. The lateral cephalogram, while less useful for transverse assessment, aids in identifying mid-face deficiency, vertical growth pattern, and the tongue posture issues that can contribute to functional crossbite. The panoramic radiograph, it helps to detect the missing teeth, impactions, ectopic eruptions, or the eruption asymmetries that may cause unilateral dental crossbite. For complex cases, CBCT provides a three-dimensional evaluation of skeletal width, buccolingual tooth positions, TMJ asymmetry, and airway and nasal cavity morphology. Invaluable in surgical planning or expansion when conventional radiographs are not sufficient. Radiographic pattern differs by etiology. Skeletal crossbite shows reduced maxillary skeletal width, functional crossbite present with normal skeletal base but center relation and centric occlusal discrepancies, and the dental crossbite shows normal skeletal proportions with isolated tooth malposition. The table here highlights the red flags one should never miss in the clinic. If the patient has bilateral crossbite that does not change when the jaw is guided, or the measurement is indicating a severe transverse discrepancy, always think of skeletal. These patients need expansion, not just a tooth alignment. You may pause the video here and take the screenshot of these two tables which compares the functional, dental and the skeletal crossbite. You would be able to diagnose in the better way. The management part of posterior crossbite. Start with the careful assessment, history, facial symmetry, occlusion in centric relationship, and intercuspation and diagnostic records. Our first clinical question should be, does the mandible shift on closure? If a shift is present, treat the interference first. Use selective equilibration or bite raising guide to allow the mandible to seating centric relation. Reassess after deprogramming. If it resolves, short term guidance and monitoring usually is sufficient. If not, pursue skeletal or dental reassessment again. Early treatment prevents permanent asymmetry. If the maxilla is narrow, plan expansion based on the growth. For growing patient, rapid maxillary expansion or RME separates the midpalatal suture and gives true skeletal gain. Slow maxillary expansion is gentler for mild cases. Overcorrect slightly and retain the appliance passively for months to allow bone fill. For adults, surgically assisted rapid palatal expansion or orthodontic surgery is often required, followed by orthodontic finishing. Is a critical role in expansion planning. In younger children, we prefer slow maxillary expansion to allow the soft tissues and developing sutures to adapt gradually. A simple removable plate works wonders here. In the late mixed dentition, we shift to rapid expansion because the mid-palatal suture is still responsive, allowing for true orthopedic whitening. By adolescence, the suture begins to resist separation, so RME may need surgical assistance. In fully grown adults, expansion without surgery is almost impossible. Here, surgically assisted rapid expansion is the gold standard. RME and SME, they differ mainly in their rate, mechanism and clinical effects. RME is activated quickly, usually 0.25 mm twice daily, achieving expansion within 1 to 3 weeks and producing more skeletal changes and less dental tipping. It is best suited for a growing patient with open mid-palatal suture who have moderate to severe skeletal constriction, often using appliances like HAS or Hyrex. SME, on the other hand, uses a gentler activation rate of around 0.25 mm every other day, taking 2 to 3 months to achieve expansion. It produces more dentoalveolar tipping and less skeletal changes, making it ideal for mild to moderate constriction, especially in younger children, with appliances like cord helix, W arch, or removable plates. Semi-rigid expansion is a form of maxillary expansion that sits midway between slow and rapid methods in terms of force levels, activation rate, and biological response. Commonly, activation is about 0.25 mm per day. That means once daily screw turn, producing expansion over 4 to 6 weeks. We've already discussed it. SARPE is used in adult patient where the mid-palatal suture has completely closed or fused and it creates a huge hindrance or resistance in opening the suture. So in these patients we have to surgically open the suture. MARPE or micro implant assisted rapid palatal expansion works by placing small titanium screws directly into the palatal bone. These screws act as anchor, so when expander is activated, the force is delivered straight to the skeleton rather than through the teeth. This approach allows us to achieve true skeletal widening in older teenagers and even some adults without the need for surgery. MARPE bridges the gap between traditional RME and SARME. It gives us a non-surgical option for those cases that are borderline for skeletal maturity. So MARPE is preferred over SARPE in patients aged around 15 to 25 years age whose CBCT shows the mid-palatal stage suture in stage C or partially fused stage D. SARPE is reserved for the older patients or those with complete stage D or stage E fusion where the suture is too resistant for non-surgical methods. This mid-palatal suture stage classification is given by Angugliari in 2013. They proposed the CBCT staging system from A to E and correlated it with patient age and treatment planning. So according to them, they recommend Marpe for partially fused sutures in late teens or young adults, or Sape for fully fused sutures or older adults. So this was all about the posterior crossbite and its management. Thanks for watching the video. If you found this video helpful, please like, share and subscribe for more videos like this. See you in the next video. Till then, bye bye, take care, have a nice day.